Welcome to Cardiac Pharmacology 101. This is going to be a quick and basic overview of the cardiac medications we use in pre-hospital care, as well as some of the medications that are commonly taken by our cardiac patients that can have an impact on what we're assessing and how we're treating our patients. To start with, quick review, autonomic nervous system. We know that the system is made up of the sympathetic and parasympathetic systems, and that's critical to remember when we're talking about cardiac pharmacology, because a huge amount of the medications and strategies that we use in managing cardiac patients are related to stimulating or blocking various components of these. During stress, our sympathetic system dominates, so that's that fight or flight response, that adrenaline response, and during rest, obviously the parasympathetic system dominates, which is that rest and digest phase. The sympathetic nervous system prepares us to respond to any kind of stressor, and in that process it increases heart rate, strengthens the force of cardiac muscle contractions, and provides other adaptive responses, such as increasing respirations, decreasing GI motility, sending more blood to the muscles, and that kind of thing. The primary neurotransmitter is norepinephrine, and epinephrine is also a key factor there. So this table just sort of reviews the different receptors that we talk about. And you see alpha 1, alpha 2, beta 1, beta 2. Alpha 2 is really not a factor in emergency medicine, at least in the pre-hospital setting. And it's not that it doesn't have some role and some impact, it's just very minimal compared to the others that we evaluate. So we really are interested in what medications affect alpha receptors, which are mostly vasoconstriction, as you see here, and beta receptors. Beta 1 primarily affecting the heart, beta 2 affecting the having a lesser effect on the vasculature and a primary effect on smooth muscles, such as in the lungs and causing bronchodilation. Sympathetic nervous system medications that we need to be aware of and familiar with include these three: norepinephrine, epinephrine, and dopamine. These are all sympathetic stimulation medications. These all are going to stimulate the sympathetic nervous system, which is why we call them sympathomimetic medications. And norepinephrine, also known as Levophed, is going to primarily affect alpha receptors, meaning it's going to primarily cause vasoconstriction, and that's how it raises blood pressure. It has some effect on heart rate, but minimal. Epinephrine, we know, hits all the receptors. It has alpha, beta 1, beta 2 effects, so it's hitting everything, which can be helpful in some circumstances, like an anaphylactic shock, but also can be problematic if we're trying to be targeted in our approach. We need to be aware that it's going to have a lot of widespread effects. Dopamine is an interesting drug in that at very low doses, it's thought to possibly have some impact on the kidneys, but that's not really well established. At the mid-range doses, which is typically 5 to 20 micrograms per kilogram per minute, which is the dose range we use it in EMS, predominantly it gets cardiac effect, primarily increased inotropic and chronotropic. So we get more squeeze out of the heart and we get some increase in heart rate. So we use it in patients who are in congestive heart failure that we really need to try to increase the efficiency of the pump. Dopamine's also interesting. If you get up high above that 10 to 20 micrograms per kilogram per minute or higher, what you get is mostly alpha response. And at that level, it works very similar to norepinephrine in that you're going to squeeze down the periphery, raise blood pressure by squeezing the vasculature. But whenever we're doing that, we have to remember that comes at a cost, that we're reducing the distribution of blood somewhere in the heart in that process. Albuterol is another sympathetic nervous system medication that stimulates that system, and obviously primarily beta 2, which is affecting the lungs, and primarily hits the lungs because we deliver it via nebulizer, so we deliver the medication directly to the target. Propranolol, atenolol, sotalol, any of the drugs that end in olol, and a lot of them that end in lol, LOL, are beta blockers. So we're still working on the sympathetic nervous system, but now we're blocking beta stimulation. We're trying to block that increase in heart rate. We're trying to block that increased vasoconstriction to achieve the exactly opposite effect. We don't use beta blockers extensively in the field, but a lot of patients are taking them for chronic management of disease situations. The parasympathetic nervous system prepares us to rest and digest. It lowers heart rate, decreases respiration, triggers adaptive responses like increasing GI motility. This is when you're able to digest. And the primary neurotransmitter in that system is acetylcholine. The good news is this is really easy to remember in terms of the drugs we use. In EMS, the only medications we use that have a direct effect on the parasympathetic system are atropine, which we use for cardiac purposes because it blocks the parasympathetic tone at the SA and AV nodes, increasing heart rate, which is why we use it in symptomatic bradycardias. And the other is Atrovent. Generic name is ipratropium bromide, which you should be familiar with, and it blocks parasympathetic tone in the bronchioles, which causes them to relax and bronchodilate. Antihypertensive drugs are not something we typically use in the field in EMS because hypertension is a long-term control issue. And even hypertensive crisis, we've learned over the years, if you drop that high blood pressure too quickly, it can sometimes cause more problems than it solves. So we don't typically do this, but a lot of our patients are on various medications to control their hypertension. Diuretics, calcium channel blockers, beta blockers, ACE inhibitors. I'll talk about each of those a little bit more. ARBs, which are angiotensin II receptor blockers, is one specific strategy going at the kidneys at that particular part of that compensatory mechanism in the body to try to work counter to the body's natural efforts to raise blood pressure. And then alpha blockers is another category that we don't see as commonly, but obviously if we know alpha stimulation causes vasoconstriction and raises blood pressure, if you block some of that stimulation, you can decrease the amount of constriction and lower blood pressure. Diuretics, also known as water pills commonly, are used for patients with chronic fluid overload, and sometimes it's used for patients with hypertension, especially a simple hypertension, not very complicated. They'll start on a very mild diuretic to try to pee off some of the fluid, remove excess fluid. With that fluid removal, keep in mind that sodium also leaves the body, and with it, potassium often does, which is why oftentimes these patients take potassium supplements as well as their diuretics. And when either of those gets out of whack, or doses are missed or excessive doses are taken, you can end up with variations of sodium and potassium that can create some significant cardiac issues. We have a lot of our cardiac patients that have angina, and there's a lot of medications that are used to control that. The most common are probably nitroglycerin and isosorbide or Isodil. They cause vasodilation, which is awesome if they do what we want, which is to cause coronary vasodilation. Opens up, increases the blood flow to the heart, and reduces the ischemia, reduces the pain. Keep in mind that vasodilation is not specific to coronary arteries only, which is why these can produce significant hypotension, especially if patients take multiple doses of them. Some patients use them occasionally, rarely, maybe once a week, once a month, even less frequently than that. Other patients use it on a daily basis, so there's a whole variety. So it's important that you figure out what is the norm for that patient. How often do they normally take it? How many have they taken today? And did it work? One of the key things with angina is that we classify stable angina as that patient I just described who has chest pain occasionally, and that's why they have this medication at home. They take it when they need it, and it solves the problem. That's stable angina. If today they've taken their medication like they normally do, but the pain didn't go away, then one of two things is probably happening. Either they've moved beyond stable angina to unstable angina, meaning that they're no longer really able to control it with their usual routine, but it's not yet an MI. The other possibility is they are having an MI. And obviously anyone who has a cardiac history to the extent that they have angina and have medication at home for it are in a risk category for developing an MI. So you need to ask specific questions to figure out, is this their normal angina? Is it worse than their normal angina? And what other clues are there that maybe we have an acute event going on that's new for this patient? Calcium channel blockers block that calcium reuptake into the cardiac muscle. And remember, we talked about the action potentials. There's that plateau phase, and the action potential, each individual cell can't repolarize until it moves across that plateau. Plateau is where calcium moves across the channels. Well, if we block those channels, calcium doesn't move as quickly, and as a result, we slow the conduction rate. That's why these medications work well for tachycardias. However, we're also decreasing the available calcium for the muscle, which means we're going to decrease contraction strength and potentially decrease cardiac output. So that's an important side effect that we need to be aware of. So if you look at the list here on the page right now, verapamil has been around for 100 years, and it's not used as widely now because diltiazem or cardizem is safer. Cardizem doesn't seem to drop blood pressure as dramatically as verapamil did, so verapamil is still around, but it's not used as widely. And nifedipine is a medication that's used primarily as a prescription med that patients take on their own for hypertension, for rate issues sometimes, using those calcium channel blocking properties to try to control a chronic condition. And diltiazem, as I mentioned, is a pre-hospital emergency medication, but you may also see patients who are prescribed cardizem and take it on a regular basis. Beta blockers, we already talked about briefly. They block beta receptors, so they're going to decrease rate, they're going to decrease contractility, so we refer to that as a negative chronotropic if they're slowing the rate, or a negative inotropic effect if they're decreasing contraction strength. Primarily, you're going to see these used for patients with hypertension or patients who have had a prior MI, especially recently. Post-MI, patients are put on beta blockers often because it's thought to have a cardioprotective effect and decrease the chance of subsequent additional MI. ACE inhibitors, remember that ACE is the angiotensin converting enzyme. And so in the kidneys, as the body senses a need to raise the blood pressure, or inappropriately thinks it needs to raise the blood pressure, that enzyme kicks in to make that progression occur. Well, if we inhibit the enzyme, we slow down that progression, which results in less increases in blood pressure. Or to look at it differently, it's a way to lower the blood pressure. That's why patients are prescribed those. Typically, ACE inhibitors are not used in a pre-hospital setting, although you may see that, especially in some critical care settings, but mostly it's a prescription that patients are going to be prescribed at home. And the clue is it ends in pril, P-R-I-L. Just about anything ending in pril is an ACE inhibitor medication. Anti-dysrhythmic drugs is a big category. So these are a whole variety of drugs that we use to manage dysrhythmias. And as we work through all the ECG rhythms and we talk about the different dysrhythmias, there's different strategies that seem to work the best on different specific dysrhythmias. And so patients may be on anti-dysrhythmic drugs at home because they've had arrhythmias in the past. And this list shows a whole variety of them that you will see. And this is a partial list. Obviously, there's a lot more. There's only 2 on this list that are commonly used in EMS. The first is amiodarone, which is the go-to current sort of in vogue drug for managing ventricular dysrhythmias. And the other is procainamide. And procainamide is another one that's been around for 50 years, and it was very widely used long before amiodarone was created. It sort of fell out of favor with other drugs being used first. And now it's coming back. There's some specific recommendations in ACLS, and it's still considered a good drug. There's some challenges to how it's administered and the timing and things like that we'll talk about. The other one that's not on this list is lidocaine. And lidocaine has been around forever as well and was used for controlling ventricular rhythms. It's basically used at the same place in every algorithm as amiodarone. And in some EMS algorithms, in some EMS protocols rather, they use lidocaine, they don't use amiodarone. Lidocaine is cheaper. It seems to be just as effective according to some studies. Other studies claim that amiodarone is much better. Jury's still out, but they both work very similarly by primarily blocking sodium channels. And you may see both of those in use depending on where you work. Anticoagulants are not something we give in the field, but is something we are very, very frequently going to see with our cardiac patients, especially patients who have had stents, patients who have had prior cardiac surgery, people with atrial fibrillation. Anybody who is at risk or prone to clotting gets an anticoagulant. And they basically work, there's a variety of them out there, and they each work a little bit differently on different components of the clotting cascade. And so for clots to form, there's a whole series of steps that have to take place. And if you can disrupt certain parts of that, you prevent those clots from forming and that from happening. And so you'll see Plavix, Coumadin, Pradaxa, Xarelto, a whole variety of them out there, and probably new ones coming all the time. Another key concept I've mentioned before in class, but I want to emphasize again, is the therapeutic index. Keep in mind that this is a really important concept with medication administration. And I say concept because we don't really have a way to measure this. So in the field, we're guessing. We are trying to accomplish what this graph is intended to represent, which is on the left, it tells you the plasma concentration, how much of a drug is in your patient's system. And across the bottom is time. So you can see from the black line that if we give a big dose of medication, we immediately create a peak. And that peak effect is the maximum amount that we're getting into their bloodstream. And then based on that drug's profile, we'll determine how long it stays in their system before it stops being effective. The green band here is the therapeutic window. That's what we're shooting for. If we are below that, which is that minimum dose, that desired response, then nothing happens. If we're above that, we're getting into side effects, bad things that we don't want to see happen. So we're always shooting for that therapeutic window. And the therapeutic index is simply a measurement of how broad that window is. In other words, how much room do you have to play with before you're getting into toxic range? So this is something we should have in our mind when we're giving drug doses, is when we're deciding whether or not to give an additional bolus, which causes an additional peak, versus hanging a drip, which flattens out that line and hopefully maintains a level in the bloodstream that accomplishes what we're trying to do with the given medication. Multiple medications is something else to think about because most of our patients are taking a lot of medications. And we need to be aware both in terms of their own medications as well as when we give multiple medications or our medication administration combined with what they already have in the system. And this is not a precise process, but it's important to recognize the mechanisms and how they work so you can try to anticipate some of these. We know that some medications will interfere with the effects of other medications. We know that some will potentiate, meaning they get a greater effect, a stronger effect when they're given. Synergism is very similar to that, although synergism is usually described as being that you do A plus B and you don't get a bigger effect of A or a bigger effect of V, you get effect C, which is something you may not even see at all with either of those drugs individually. So knowing that the patient response to drugs is going to change and chances go up that their response is going to change in unpredictable ways based on how many medications they have in their system. And in some cases, one medication will cause another medication to have a completely opposite or unexpected response. We refer to that as an iatrogenic response, meaning something happened that we didn't plan on, something we didn't expect. And the most common example is an allergic reaction. But these examples of multiple medications can also fall into that. We classify drugs in a variety of ways. As I've mentioned in class before, I don't care if you memorize what number goes with the classification. I think it's more beneficial to understand and remember how they work. So we talk about chronotropic effect. Does it affect the rate? Does it affect contractility, which is inotropic? And dromotropic, which isn't mentioned as much. It's really closely tied to rate, but it's really measuring the speed of conduction from one cell to the next. And obviously, if you speed that up, the result is also that you speed up rate. And with each of these, we're talking about a positive or negative effect. When you say it has a positive inotropic effect, you're saying that you're increasing the squeeze, and a negative effect is the opposite. Cardiac glycosides are their own category. In Blackboard, I posted a one-page document about pharmacology definitions, and there's a description there that's a couple paragraphs long that really gets into the details of how cardiac glycosides, which are the digitalis products, how they work and why they work. And they're used primarily to increase contractility, but they also have some benefit of controlling or limiting fast heart rates. Within a lot of our congestive heart failure patients, both of those are beneficial, which is why most of your CHF patients will be on digoxin or some digitalis derivative. Anti-dysrhythmic medications are those medications that we use to treat dysrhythmias, as I mentioned before. And again, I don't care about the numbering, but I want you to remember where they function. How do they work in the heart? Sodium channel blockers are huge. I mentioned lidocaine, amiodarone, both work on these properties, and they tend to work very well in ventricular tissue. Potassium channel blockers, we don't have any that we give that are just potassium channel blockers, but amiodarone, for example, has an impact on both sodium and potassium, as well as some other medications. Calcium channel blockers I already mentioned, and by going after those calcium channels, we slow conduction, We decrease contractility, which can be an issue in terms of blood pressure, but can be very effective in terms of controlling rate. Beta blockers we talked about also. They block beta stimulation in the sympathetic nervous system, which will decrease heart rate, decrease contractility, decrease vasoconstriction, and potentially manage high blood pressure or potentially lower blood pressure significantly, especially in excessive amounts. And then the last one is adenosine, which is kind of its own category that's not really well understood. A good way to think about it is it basically is a chemical cardioversion. When we cardiovert someone out of a fast rhythm, we're blasting the heart with electricity in the hopes that we will reset things back to something normal and allow a normal pacemaker to take over. When we give adenosine, we are chemically essentially creating the same thing. And keep in mind, adenosine is that drug that has an incredibly short half-life, like less than 15 seconds. And so it has to be given in a large IV, large vein preferably, and immediately followed with a 20 milliliter bolus of saline to make sure the drug gets to the heart before it loses its efficacy. And it will cause people to go into asystole briefly. It will cause them to show all sorts of dysrhythmias. It can be very scary to watch on the monitor. But when it works, it often causes that disruption followed by a return to a normal sinus rhythm or whatever the patient's normal rhythm was.